All right, well, welcome everybody to our September coaching call. It's a day earlier than it usually is on a Wednesday and not a Thursday, and so we're hoping some team members might continue to join us. This will be recorded if you'd like to distribute it to any of your team members who weren't able to make it. We have such exciting stuff to cover today that I would love for you to share it out. But we're going to get started. We're going to move pretty fast today. We have quite a few things to get through, but if you have chats, questions, concerns, anything, put it in the chat. Sydney is moderating it for us. And so even though we're going to move pretty quick, if there's a resource you heard about and didn't get, or something that we said and you didn't quite catch, feel free to throw it in the chat because I'm sure you're not the only one. So we'll go to the next slide. I'm going to give you a little preview here of our agenda. We are going to do another quick welcome to our new program manager, Sarah. She's going to introduce herself again. Gretchen, our data analyst, is then going to share some data interpretation tips with us as far as quality improvement data goes. We then are going to have one of our colleagues, Carly Swenson, share some of the outcomes of the nursing stigma and bias training that we've done over the past 2 years. And then finally, we have Erica Isa, who is coming to share the very recent released MMRC data that covers data from 2016 to 2020. So super exciting release that just happened in the past month. And we're very fortunate to have Erica here to share it with us. So just moving on, Sarah, welcome. We did a brief introduction last month, but now that she's a little more settled, we're going to just learn a couple more things about her.
Yeah, hi everyone. This is Sarah Briley. I'm a program manager here with CPCQC. Just a few little facts about me. I'm born and raised in Indiana. I have my bachelor's from Indiana State University, my master of public health from Indiana University in Bloomington, so very rich in Indiana. And then I have a dog named Ruby June, who's an Australian Shepherd, and I'm an only child. So some fun facts.
Awesome, Sarah, thank you. We didn't tell you that we didn't make every team member do this. So you're piloting this for us, the 5 things about Sarah. So guys, Sarah is here. She's settled in. She is the one who's helping us make lots of logistics decisions about how the program is run, the content that we put out. If you need anything, please reach out to her. And she's going to play a big part in our programming moving forward. We're going to move to the next slide, and we're going to jump right back in. You all know, those of you that have been with us through the year, we have devoted a few minutes of every single coaching call to talk about the topics that we need to know about quality improvement principles, because SUD at its heart is a quality improvement program as we're trying to improve care for moms and infants. And this is just a rundown of the things that we've gone through this year. So we started in February, gave the basics. We talked about mission statements, aim statements, cause and effect diagrams, driver diagrams, PDSA cycles, and measures for improvement. If you are interested in any of those topics, they are all recorded and on our YouTube channel. So if any of those sound interesting to you, or you missed them, or that would be helpful for quality improvement at your site, please go back. I put our little pregnant lady here because we are now 9 months into our QI journey. And I am a midwife, and that's how I think 9 months goes, in that we are just stating our quality improvement and we're almost ready for birth. We have just a couple more months left of our quality improvement talks. So we're going to go to the next slide. Today, what we're going to do is hear from Gretchen, and she's going to teach us how to interpret data for quality improvement, and the types of data that we give back to your teams, how it is that you can gain more information by looking at that data. And still to come in the coming months as we finish out the year, we're going to talk about sustainability practices for SUD. What are the things that you could implement at your hospital to sustain the excellent work that you've done so far this year? And then we're also going to devote some time in the coming months to talk about disseminating your outcomes. So those of you who are interested in publishing, creating posters, writing about the work that you've done and sharing it, we're going to do some how-tos about that. So if you've never published, never created a poster, we're going to do just some of the basics about how do you start, where are the places that you could showcase your work, and what CPCQC can do to help bridge that for you. So in the sake of time, happy to turn this over to Gretchen, who's now going to share some data tidbits with us.
Hi, everyone. My name is Gretchen Scholes. I'm the data analyst here at CPCQC. For those of you that I met at last month's meeting, it's a pleasure to see you all again. For those who I have not gotten the chance to meet, welcome, welcome. Please do not hesitate to reach out for any data needs at any point in time. Let's go ahead and move on to the next slide. So today I wanted to go ahead and talk about understanding run charts, and these charts are used to show data over time. And so the basic elements of a run chart are really that the y-axis, the vertical here, it shows us any sort of measurement. And then the x-axis along the bottom shows us the time measurements, usually with some sort of median in the middle. These charts can be really useful to see how your data has improved or changed over time. Let's go ahead and move on to the next slide. So there's 4 main rules of run charts that can help us interpret these different types of graphs. Perfect. So the first rule is that of a shift, which states that if there's 6 or more data points that you can see here on this graph that lie either above or below the median line, there is a shift. For our purposes, this could show a change in screening rates or potential changes in clinical care practices over time that may be due to changes in protocols. These can both be positive and negative, but really just show a gradual shift in some sort of practice over time. I do also want to emphasize too that at any point in time, feel free, if you have questions or comments, please feel free to use the chat for those. The second rule is that of a trend. And this states that if there are 5 or more data points, all either increasing or decreasing, that shows a trend. And this can be, again, we're looking at over time. For example, if you've improved your screening rates for substance use disorder, you can see that there would be a gradual increase in those, there would be a gradual trend upwards of those screening rates. That's just one example, but there are many that we see within the data. But these would be either increasing or decreasing, and usually you would see this gradual incline or decline that would fall somewhere around the median point. Let's go ahead and move to the next slide, please. The third rule is that of a run. And the basic rule for a run is that there is a series of data points that have crossed over the median line. So that middle line here, which shows our midpoint between the highest data point and the lowest data point. And that shows that if there's too few times that it crosses or too many, and this is determined based on various analyses to determine what is too few or too many. However, if it crosses over that median line too few or too many times, this can show some statistically significant change. This could be an irregular health event that occurs in the hospital or in the country, a change in practices such as screenings or clinical care practices as well. Lastly, I want to move to the last rule here. And this is that of an outlier or an astronomical point. This rule is used to point out unusually large or unusually small values that appear sort of out of the ordinary. So you can see this arrow here pointing to this fairly large value over time that doesn't really follow the same trends as the values and data points below. An example of this may be that we saw some increase in various health outcomes due to COVID spikes that occurred in 2020 and 2021. That would be a significant outlier or astronomical point that doesn't really follow the usual trends of the data that had preset. And now moving to the next. So here I wanted to just go ahead and give us an opportunity to do a little practice really quickly. If you wouldn't mind putting in the chat any of the 4 rules that you see in this graph here. Some may be a little bit more obvious, some may be a little bit more, we may need to review a little bit more, but did we see any trends, any shifts, any runs, or potentially any outliers or astronomical points? And you can go ahead and use the chat for those. Great work, Amber. And we'll go ahead, for time's sake, feel free to continue putting your ideas in the chat, but let's go ahead and see what the results are on the next slide. So on this graph here, we see 2 different shifts, one that falls above the median and one that falls below. And that again is 6 points, 6 points or more that fall either above or below the central line. Great job, Amber, again on that astronomical data point that spikes up quite high there. And then also we see trends, again, that's 5 or more points that are either increasing or decreasing within the data across time. And then I want to move on to the next one. So here I just wanted to go ahead and reiterate, control charts and run charts are very similar, but have some slight differences. So they are used to measure data over time. However, they differ because this middle line here, which on run charts is usually the median, which is the middle point between the highest and the lowest data point. Here we see that that middle line here is the mean or the average of the data. So they're not exactly the same. Likewise, here on a control chart, you'll often see an upper limit and a lower limit for your data set. And then there are a separate set of rules for control charts to help us interpret those that we don't have time to cover today, but that they're slightly different. So while they may look similar, they do follow a different set of rules in terms of what is considered a trend or a shift, etc. And then lastly, I just wanted to go ahead and do a simple data reminder. I know that there's been some confusion with some of our hospital level data in submissions for the difference in demographic data that's submitted from our hospital level forms. So the first portion of that data from the hospitals that we ask for the demographics is all patients admitted for birth in your hospital. That's one data set. So that's what we see here in the orange. The subset of that is that the demographics of those who were screened. And that also occurs in that same hospital level form. So you'll report how many, the demographic, race and demographics and payer information for those that were admitted, but separately we'll also want to see the demographic data for those who were screened for substance use disorder. That's a separate component there that's also in that hospital level form. And then lastly, for all that those who were screened positive, we'll collect the demographic and payer information on the individual patient level forms that you all submit to us. So I just wanted to go ahead and reiterate the differences between those different levels of demographic data that we collect. But by all means, I know that this was not an exhaustive discussion of all the data that we share with you on the dashboards. If there are questions or concerns, or if you are interested in data and wanted to discuss in more depth, I'm always here and more than happy to discuss any of your data needs. I'll hand it back over to Amber.
Thank you, Gretchen. It's always a pleasure. We use run charts a lot, both in our data dashboards and when we're analyzing data on our side, and we're probably going to tend towards using them even more. And so as we do our one-on-ones and you guys get to talk to us about your facility level data, we're happy to do some of that interpretation with you. I am going to move on quickly here. Carly Swenson is here. She's one of our program assistants. She's done some really amazing work with nurse surveys through Colorado to shed some light on what stigma and bias for perinatal substance use specifically looks like. We're going to do a quick run through of this data. It's also going to feel a little bit fast and furious, but Carly is happy to discuss it with you separately. If you guys have questions after this, please put in your chat if you're interested in chatting with her after this. Thanks, Carly.
Awesome. Okay. Let's get started. There we go. So as we all know, suicide and accidental overdose are the two leading causes of maternal mortality. To understand, however, the experience that pregnant patients with substance use disorders or mental health concerns experience when they go into the hospital, we wanted to talk to labor and delivery unit nurses to get an idea of how these patients are treated. Next slide. Okay, so what we did, we administered a survey, which you guys may have all filled out in 2022 and then again in 2023, asking labor and delivery unit nurses about how their peers change their attitudes and behaviors towards patients that either have substance use disorders or mental health concerns. Next slide. Whoa. We're getting there. One more. There we go. This is just some of the survey participant characteristics. The main takeaway here is that the majority of respondents, of which we had almost 200, had a bachelor's in nursing. They had been in nursing at a pretty even spread between 0 and 25 plus years. So we're not only capturing new grads. And I think the most important note from this characteristic list is that 53% had been at their current facility for over 5 years. So this is some of the more pervasive attitudes that are in these hospitals, in your hospitals, for nurses that have been there for quite some time. And it's also important to note that despite accidental overdose being the second leading cause of maternal mortality, 78% said that respondents said that they don't have experience in a substance use setting. So just something to think about. Thank you. So the first important point is that the nursing staff acknowledges that their attitude impacts the clinical care of the patient. So here you can see almost 100% acknowledged some impact. The majority said that there is a significant impact on clinical care based on the nurse's attitude. And now these graphs, what you're looking at on the top is how the attitude is changing towards patients with substance use disorders, whether the patient discloses the substance use or that the nurse perceives the substance use. And what you see here that our 2023 data is between 50 and 60% report that their colleagues have negative changes in attitudes towards these patients, whether they disclose it or whether the nurse perceives it. And then the behavior is a little bit better. So whether a patient discloses substance use or the nurse perceives substance use, around 30% report that their colleagues have a negative change in behavior towards these patients. Thank you. And the rates are looking a little bit better for mental health concerns. So that is a good takeaway. However, we're still seeing 15 to 20% negative changes in attitudes towards patients that express mental health concerns at labor and delivery. And about 10% of nurses report that their colleagues have a negative change in behavior towards these patients. Thank you. And some good news. So we re-administered it this year. We did see a 10% decrease in negative attitudes. So that's good. Participating in SUD with our champions was able to decrease 10%. That's a big change. However, it decreased from about 65% to about 55%. So we're still seeing over half of the nursing staff that respond saying that their colleagues have these negative attitudes towards these patients, which is definitely an area for future intervention that we need to look at. So it's showing that champions are useful, but we need to get to the normal everyday nursing staff too. So only 5% of quantitative responses said that there's a positive change. However, when we asked a qualitative question to give examples of changes in behavior, 47% of the people who responded gave examples of positive behavior. And on the next slide, we have some examples. So we have nurses responding that their honesty is valued, that these patients are given resources, that you can be super supportive and encouraging of the patient getting clean, or you can be more aware to ask questions and monitor more closely, which are great impacts. And I'm so glad that nurses responded with these. However, if only 4 to 5% say that this is actually happening, then that's something we need to dig into. And then I believe on the next slide, yeah, there is 53% of the qualitative responses gave insight into some of these negative attitudes and behaviors. So we really wanted to do a qualitative analysis to get the nurses to give us examples, like let us know what's going on in your unit. And so I'm gonna breeze through some quotes that we got, but I just want you to kind of sit with them and recognize how these attitudes can impact the patient. So of the negative responses, we saw multiple themes. Some were negative attitude, not providing clinical care, judging the patient, talking negatively about the patient to other staff, often at the nursing desk, not trusting the patient, and also just lacking compassion. Okay. So here's an example of judging the patient, assuming that the patient doesn't care about her baby because she had a substance use disorder. An example of poor clinical care, a patient that had been in recovery for 10 years was not allowed to feed the baby or breast pump milk until they had a negative toxicology test. And this nurse responded, I feel like she was profiled due to her past. Another example of poor clinical care, not assisting the mother in bonding if you assume that the baby's going to be taken away by CPS. One of the most pervasive comments about poor clinical care is denying the patient pain medication while they're in labor, or sharing with the provider that they don't think that the patient is actually in pain. We had other reports of them being pain seeking or drug seeking while in labor. Next, let's see. Here's another example. When they complain about pain, they might be undertreated. Staff believing that Subutex is a pain medication and that it should be providing relief when it's not. Here's an example of those HIPAA violations that I was talking about. So a nurse speaking to a patient in a very short and condescending way, and then discussing the patient's substance use issues in front of the patient's visitor, which was her mother, who is not aware of the patient's substance use issues, which causes significant issues between the patient and her family. And they didn't know about the substance use, and it wasn't in that nurse's right to tell them about it. Another example of a HIPAA violation is talking about the patient at the nursing desk to other staff who don't know the medical history of this patient. So giving examples to your colleagues, saying, how could someone do that to their baby? Or hopefully CPS will just take this baby away when the nurses don't know about a substance use disorder. An example of judging the patient is calling the patients difficult to work with, or saying that these are challenging for newer nurses. When you think about it, a patient that's hemorrhaging is also pretty difficult to work with because of their medical situation. And that's very similar for these patients that are trying to manage a long-term disease. Another example of judging the patient, calling them drug addicts, assuming that they have no coping skills. And this nurse commented, it's awful and I feel like her needs are not met, which I think is a good example of how these attitudes can play out. Another example of poor clinical care, and this is one of the quotes I use pretty often because I think it sums it up. I've witnessed this with my colleagues and even in myself when all you want to do is the bare minimum for these patients and not want to get them the added support or help they may need or even deserve. I think that this really summarizes the experience that patients have when they go into labor and delivery already scared and already vulnerable. Negative attitude was very pervasive. This nurse responded, it's hard to have a positive attitude when they've knowingly used substances in pregnancy, which is one of the most common responses we got. Judging the patient, calling them difficult to work with, saying it's hard for new nurses. Again, we need to provide that training so new nurses are comfortable with these patients just how they would be with a hemorrhage. We did unfortunately see some pretty explicit examples of racism. For this one, it was sometimes patients who are abusing drugs will have an attitude and mistreat nurses and be uncooperative. Some are Native Americans who have a clear disdain for white people, and that complicates the nurse's plan of care. There needs to be equal sympathy for what nurses go through in difficult situations. So this is that assumption that Native Americans are using substances more often and are also not complicit in their care. And then on the other hand, we had people saying ethnicity's never been an issue in our unit. It will never be an issue in our unit. I do not feel it is wise for us to look at our opinions regarding the nursing opinions about attitudes and behaviors to base whether or not someone is being treated appropriate. I think we are working too hard to make race an issue in places it isn't. And I put that intentionally following one example of the racist comments that we get, because I know that people want to assume the best about their hospitals and their teams. But it is in your hospital because this is who responded to the survey. Next slide. An example of poor clinical care. I appreciated this one. She said, The nurse the previous day had been hounding her about her substance use and that it made her extremely upset and anxious. So this is an example of the nursing behavior that did not need to happen that harmed this patient's experience. Stigmatizing language. We won't be fixing a drug abuser in the time of labor and delivery. Not only they don't need to be fixed, but also this highlights that it's not a knowledge that substance use disorder is a chronic medical condition, but instead a personal moral failing. This example of poor clinical care is about as far as I will go into this, but taking care of substance use disorder patients does not fit with this nurse's personal, moral, or religious beliefs, and not something that they will ever implement into their practice. But I think, as we know, when taking care of vulnerable patients, personal, moral, or religious beliefs should not be affecting providing clinical care to patients who need it. And so those were many of the responses we got that showed examples of attitudes and behaviors. But some of the responses were so useful because nurses have questions about perinatal substance use. They're not being informed. Here's just a few examples of some specific questions that we got when we didn't even ask for it. And if we go to the next slide, this last quote is the one I wanted to end it with, that we need to do better. This nurse said, how they're treated is absolutely awful. There's a blatant disregard for patient confidentiality. Nurses are horribly undertrained. And as an RN, it's heartbreaking to see how these patients' care is subpar, even though they're vulnerable and in a very stressful life event while at labor and delivery. So nurses acknowledge that we need to do better. And they want training. We had so many reports saying we would give better care if we had training. Please give us training. So we wanted to answer that call. And we have, there we go, October next month is Substance Use Awareness Month. So we want to answer that call from the nurses and improve care for pregnant patients with substance use disorder. So in October, we are piloting a stigma and bias training. I'm so thankful for everyone who's already started to register. Keep in mind, this is, though champions are welcome, you are more than welcome to attend the event. The intended audience is the normal L&D unit staff, the people who are making these changes on a day-to-day basis. So we're providing free, virtual, online trainings. It's a combination between CPCQC, the Moms Plus team, and the incredible lived experience experts over at Hard Beauty. And we're going to be covering clinical and social determinants of health curriculum. We're going to have discussions with lived experience experts who had substance use disorders in their own pregnancy. And they say no question is off the books. If you have questions, we want you to ask them. We're going to have opportunities to ask anonymous questions. And also, we're going to be running through some scenarios of what can be done to intervene in situations. We know that everyone who's attending our calls has the best intentions, and they want to be the best, most trauma-informed care providing nurse that they can be. But for this education to become more pervasive throughout the unit, we need to make sure that people are comfortable intervening when they see their colleagues having these negative attitudes and behaviors. So we're going to go through some of that. And so these are the first 3 training dates. We tried to schedule them so they would be good with shift work and everyone's crazy schedules. Here's the QR codes. I will also drop the links in the chat. We're providing CE, and there's 10 $50 gift cards that are going to get raffled off to attendees, going straight to the nurse who attends it. And I will, like I mentioned, I'll send the one pager in the chat. But if you wouldn't mind sending this to your C-suites, posting it on your unit, we want the most engagement from people who haven't been involved, from the nurses who haven't really been involved with the CPCQC initiatives. as we can. So yeah, please distribute. And I think that was my last slide. So yeah, I'll also put my email in the chat. So let me know if you have any questions.
Thank you, Carly. Actually, while I introduce Erica, you can just leave the last slide up with the QR codes if you want to. Please share it widely. The target audience is labor and delivery nurses, but we are not opposed to you sharing it with your NICU staff. And so if you have nursery nurses that are interested, they're welcome to attend. The $50 raffle gift cards are just a starting point. We're looking for more incentives. More incentives may be coming to help your nurses offset the time that they spend in this training. We'll keep you updated if we can, if we get more incentives to have the nurses attend and compensate their time for attendance. There is CE, and so if that is an incentive for any of your nurses attending, please let them know. We are super excited to have Erica Issa with us. She is a maternal and child health analyst with the Colorado Department of Public Health and Environment, and she's here to share hot off the press data about maternal mortality in Colorado. Thank you, Erica.
Yes, thank you for having me. Let's get my screen shared. All right, you can all see my slides now? Yep, okay. So today I'm going to give an overview of maternal mortality in Colorado. Data for this presentation comes from the Colorado Maternal Mortality Review Committee, and as Amber mentioned, they are included in the legislative report that was published just last week. So the goals of today's presentation is that after the presentation, you should be able to understand the Colorado MMRC and how it operates. You should also understand the leading causes and contributors to maternal mortality in the state, and understand the recommendations the MMRC makes and how audience members can advance them in their own practice. With maternal mortality being a very hot topic nationally, you might have heard of different ways of measuring maternal mortality, whether it's data from the National Center for Health Statistics that looks at deaths during pregnancy through 6 weeks postpartum, or national pregnancy-related deaths from the CDC. But if you really want state-specific data, you need to turn to maternal mortality review committees. They're really the gold standard on getting data at the state level. And this is for a few reasons. First off, MMRCs review all deaths of those who are pregnant at the time of death or through 1 year postpartum. And this includes reviewing accidental deaths, such as motor vehicle collisions or other injuries, as well as violent deaths like homicides and suicides. Some of the national data excludes these type of deaths. And then MMRCs incorporate multidisciplinary expertise, and they're typically staffed and hosted by the public health agency. So in Colorado, the Department of Public Health and Environment oversees the MMRC, and we have a ton of different expertise on our review committee. We have experts with lived experience in the drivers of maternal mortality, doulas and birth support, forensic pathology, health systems experts, home visiting, patient advocates, public health, rural health, social work, and a variety of medical expertise, including addiction medicine, maternal fetal medicine, midwifery, obstetrics, nursing, and behavioral health. And so the goal of MMRCs are to understand the drivers of a maternal death and determine what interventions would have had the most impact to prevent the death, so that this data can be used to prevent future death. So MMRC case review is based on comprehensive case narratives, which are created by our nurse abstractors, and they pull data and information from the death certificate, birth or fetal death certificate, from coroner's report and autopsy records, from medical records that can include things like prenatal care, postpartum visits, emergency department visits, behavioral health visits, primary care, all scope of medical records that we have available, toxicology reports, data from the prescription drug monitoring program, social media, police records, national violent death reporting system data, the state unintentional drug overdose reporting system, as well as they look at obituaries. So for each case, the MMRC first determines what was the cause of death, and do we agree with what it says on the death certificate? We then look at the circumstances that contributed to the death, and so for this we ask, did obesity contribute to the death? Did mental health conditions contribute? Did substance use contribute? Did discrimination contribute? And then Colorado added specific questions around, did COVID contribute? And did cesarean sections contribute? We then look at manner of death for suicides and homicides. And then the most important question we look at is, was the death pregnancy related? So would this person have died if they had not been pregnant in the last year? From there, we generate recommendations which are actionable steps that would have prevented this death. And then finally, we look at preventability. So was there some chance to alter the outcome at the patient, provider, facility, system, or community levels? It's important to understand both what the MMRC is and is not. So first, the MMRC is an ongoing, anonymous, and confidential process of data collection, analysis, interpretation, and action. The MMRC review is a systematic process that is guided by policies and statutes and is intended to move data from collection to prevention. We also feel that the MMRC case review can be a last word for the decedent. By comparison, the MMRC is not a mechanism for assigning blame or responsibility for any death. Since all case review is anonymous and confidential, we don't look at which hospital the death occurred at or what providers were involved in it. And so we're not trying to place blame, we're just trying to understand what happened. It's also not a peer-reviewed research study. It's designed for public health surveillance and not for clinical research. It's also not a substitute for existing mortality and morbidity inquiries that may take place in hospitals and have their own benefit. The MMRC is also not the body that enacts recommendations. We make recommendations, but then we rely on our partners who are involved in this work to actually implement these recommendations. So moving on to the actual data. This data comes from deaths that happened in 2016 to 2020, and it's the data that we present in the legislative report that was just published. Starting with some definitions. So first we have pregnancy-associated deaths. So these are all deaths that occur during pregnancy or within 1 year of the end of pregnancy, regardless of the cause of death. By this definition, pregnancy can end by live birth, stillbirth, fetal death, miscarriage, or abortion. The Colorado MMRC reviews all pregnancy-associated deaths among residents of the state. So we look at deaths among people who lived in Colorado. Typically, the people who lived in Colorado also died in the state, but we do occasionally look at some deaths of Colorado residents who died out of state. But that does mean we don't look at deaths from out-of-state residents who died in Colorado. Their state's MMRC look at those cases. So then we have pregnancy-related deaths, which are a subset of pregnancy-associated deaths, where the death is due to a pregnancy complication or a chain of events initiated by the pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. And so this big outer circle in blue, these are our pregnancy-associated deaths. That's anyone who died during the time period of pregnancy or 1 year postpartum. And then we have a subset of those deaths in green. Those are our deaths where the person would not have died if they had not been pregnant within the last year. This presentation primarily focuses on that pregnancy-related deaths, so those deaths where the person wouldn't have died if they had not been pregnant in the last year. But we do have a few data points among those, all of pregnancy-associated deaths, so all deaths in the time frame. I'll use the blue and green from this figure throughout the presentation. So if you see data in blue, that's all pregnancy-associated deaths, so all deaths we review. And data in green is the pregnancy-related death, the subset of deaths that are directly related to the pregnancy. From 2016 to 2020, there were 174 pregnancy-associated deaths in Colorado. This represents a pregnancy-associated mortality ratio of 54.7 pregnancy-associated deaths per 100,000 live births. We use mortality ratios rather than counts, so we can standardize the number by the population size and make comparisons. If you have 10 deaths in a population of 100 people, that's going to be a much larger proportion of deaths than 10 deaths in a population of 100,000 people. And so that's why we use ratios. Of those 174 pregnancy-associated deaths, the MMRC determined that 80 of the deaths were pregnancy-related. So this represents a pregnancy-related mortality ratio of 25.1 pregnancy-related deaths per 100,000 live births. Since pregnancy-related deaths are a subset of pregnancy-associated deaths, pregnancy-related mortality ratios will always be smaller. So we know maternal deaths are occurring in disproportionate rates among certain populations. So here we're looking at mortality ratios by race ethnicity. And as we dive into this data, it's important to note that while all populations of color experience structural and systemic racism, the greatest maternal mortality disparities in Colorado exist for our Black and American Indian Alaska Native birthing people. So we're going to focus on those two groups. So first, we have the pregnancy-associated mortality ratios. among American Indian and Alaska Native birthing people. So we can see that American Indian and Alaska Native pregnant and postpartum people were 2.8 times as likely to die during pregnancy or within 1 year of the end of pregnancy compared to the overall population. We can't look at the subset of pregnancy-related deaths, so those deaths that were directly related to the pregnancy, for this group, due to our internal suppression criteria. We suppress if there's fewer than 5 deaths in a category, and we do that to maintain statistical reliability and to protect the confidentiality of those who died. But national data shows that American Indian and Alaska Native pregnant and postpartum people were 1.8 times as likely to die from pregnancy-related causes than the overall population. So looking at data for Black birthing people, here we can see that Black pregnant and postpartum people were 1.9 times more likely to die during pregnancy or within 1 year of the end of pregnancy compared to the overall population. We are able to look at pregnancy-related data here, and so we see, consistent with national trends, that Black pregnant and postpartum people were 2.1 times more likely to die from pregnancy-related causes compared to the overall population. So more likely to die of those deaths that are directly related to the pregnancy. So starting in 2017, the MMRC has asked whether discrimination contributed to the death, and the definition we use for discrimination is treating someone less or more favorably based on the group, class, or category they belong to, resulting from biases, prejudices, and stereotyping. It can manifest as differences in care, clinical communication, and shared decision-making, and it can encompass institutional, interpersonal, and structural racism, as well as any bias based on any additional identity or system of oppression. And so we see that discrimination contributed to more than half of all pregnancy-related deaths, so to 58.2% of all pregnancy-related deaths. And some of the ways the committee has identified discrimination includes things like race and ethnicity, insurance status, behavioral health history, age, socioeconomic status, involvement with the carceral system, and other factors. So looking at causes of pregnancy-related deaths, you can see from this graph that the leading causes of pregnancy-related deaths were obstetric complications, suicide, unintentional drug overdose, cardiac conditions, and sepsis or infection. Sepsis and infection also includes deaths from COVID-19. I'm going to do a bit of a deeper dive into a couple of our leading causes of death, starting with suicide. So suicide is the second leading cause of pregnancy-related deaths, so those deaths that were directly related to the pregnancy. And some of the ways that we've seen suicides be pregnancy-related include when a person experiences depression for the first time during or after pregnancy, when mental health significantly deteriorates during pregnancy, or if the stress of the pregnancy contributes. So when we compare the percent of all pregnancy-related deaths from suicide to the percent of deaths among the population of reproductive age, which here we're looking at women ages 15 to 44, we see there's a significant difference, and pregnancy-related deaths were 2.1 times as likely to be from suicide as deaths among the population of reproductive age. So there is that increased risk of suicide in this time period. We're also able to look at the timing of when these suicide deaths happened. We broke that up into 2 time periods: during pregnancy or the early postpartum period, so 0 to 6 weeks postpartum, and the later postpartum period, so 6 weeks to 1 year postpartum. We see that over half of all pregnancy-related suicides are occurring in that later period between 6 weeks and 1 year postpartum. And that means that over half of all suicides that are related to the pregnancy are happening after the standard 6-week postpartum checkup when there's not routine postpartum care anymore. So the other cause of death I'm going to look at is unintentional drug overdose, which is our third leading cause of pregnancy-related deaths. Some of the ways we've seen unintentional drug overdose deaths be pregnancy-related are if there's new substance use related to opioids or other medications prescribed for pregnancy-related conditions. There's an increase in existing substance use to cope with either the stress of a pregnancy or with pregnancy loss, or an overdose after decreased tolerance related to abstinence from substance use during pregnancy. Because of our internal suppression criteria, I can only show you one time point for unintentional drug overdose deaths, but you can see that 64% of unintentional drug overdose deaths occurred between 6 weeks and 1 year postpartum. Once again, this is after routine postpartum care would have ended. And these are the deaths that are specifically related to the pregnancy, where the person wouldn't have died if they hadn't been pregnant in the last year. So now taking a step back and looking at all pregnancy-related deaths, not just a specific cause of death. For each case, the committee asks whether substance use contributed and whether mental health conditions contributed to the death. So we wanted to look at the full breadth of behavioral health, and we see that either mental health conditions or substance use contributed to 1 in 2 pregnancy-related deaths. But as I just showed you, a large portion of pregnancy-related deaths were from suicide or unintentional drug overdose. So we went one step further. Among deaths not due to suicide or drug overdose, 1 in 5 people had either mental health conditions or substance use as a contributing factor in their death. We think this really highlights that behavioral health conditions have a far-reaching impact beyond just those deaths that are due to substance use or due to unintentional drug overdose or suicide. Before I move on to the recommendations, I want to leave you with this. 89% of pregnancy-related deaths were preventable, which means that 89% of those people who died would still be alive if there was some reasonable change at the patient, provider, facility system, or community level. And the preventability is even higher when you look at suicide or unintentional drug overdose deaths. 100% of deaths from suicide or unintentional drug overdose are considered preventable, so all of those people could still be alive today if there'd been some reasonable change. So the MMRC generates tons of recommendations for each case we review, and we made over 1,000 individual recommendations in this time period. We broke it down into 13 sort of buckets of recommendations, which are all listed here. You can read all of these recommendations in the legislative report, and I'll drop the link after this. But the ones in bold are the ones I'm going to sort of touch on. But I also want to remind everyone that maternal mortality is just the tip of the iceberg. There's lots of other adverse maternal outcomes, including near misses, severe maternal morbidity, and maternal morbidity in general that may require some type of additional medical treatment. While we only review deaths in the MMRC, we hope that these recommendations will be implemented to address all types of adverse maternal outcomes and improve maternal well-being throughout the state. So the recommendations are long, and I don't want to read all the text that's on the screen, but I'll try to highlight the key pieces. So the first piece of our equity, bias, and discrimination recommendation is that systems that provide care for pregnant and postpartum people need to continually work to address the current and historical impacts of oppression and racism within care models. We know there are disparities in maternal health and well-being, which we see starkly in our maternal mortality ratios for Black and American Indian Alaska Native people. And we also know that discrimination affects a whole host of marginalized populations based on their identities, and that it's everyone's responsibility to work on addressing this. So the recommendation has a second piece around systems and communities partnering with and investing in community partners, peer support persons, tribal leaders, those with lived experience, and all of those people out there that are already doing incredible work to address bias and discrimination. We don't need to reinvent the wheel, but we can make sure to partner with and learn from those who are already doing this work. So we have a large recommendation around screening and follow-up. We recommend that all healthcare providers use evidence-based screening tools to address mental health, substance use, suicidality, intimate partner violence, and social determinants of health. And when we say screening, we mean using an evidence-based and validated screening tool, not just using urine toxicology, because we know that comes with a whole host of other issues. And so we also know that screening to just fill a checkbox or requirement is not enough. We need to be screening regularly so that we can really try to identify any issues. And then there also needs to be follow-up. Regardless of the result, there should be a follow-up relational conversation discussing the screening that gives the patient time to address their concerns. Screening only works if the patient feels heard and feels like they can actually talk about what's going on. So looking at education and public awareness around stigma reduction, as all of you know, and as we just saw tons of examples of from Carly's presentation, there's tons of bias and stigma around behavioral health conditions, especially in the perinatal period. And so because of this, it's really important that communities, systems, and healthcare providers are actively working to break down this stigma. We then developed specific overdose recommendations that centered around naloxone. So the recommendation focuses on the fact that naloxone should always be co-prescribed with any opioid prescription and should be available and easy to access. And we really feel that anyone who uses substances or knows someone who uses substances should be able to access naloxone. We also made recommendations around improving clinical quality, with a large focus that healthcare facilities need to implement AIM bundles to improve patient outcomes. In Colorado specifically, we really see a need for implementing bundles that address supporting patients with substance use disorders and mental health challenges. And we acknowledge that facilities need more practical support and funding and protected staff time to really make this happen. The last recommendation I'll touch on is around improving capacity and access. We need more healthcare professionals who can support people during pregnancy and the postpartum period. That means we need more doulas, more midwives, more behavioral health professionals, more peer support, more care coordination, traditional practitioners, home visitors, lactation consultants. We need more of these people. And we know there's especially a need for improving access to culturally and linguistically appropriate services, and especially improving access in rural and frontier communities. So the 5 action steps I'll leave you with are: we need to expand the perinatal behavioral health workforce. We need to continue to connect people to naloxone. We need to follow up screenings with relational conversations. Our language matters, so we need to keep helping to fight stigma. And we really need to increase the number of hospitals participating in AIM bundles. All right, thank you all for taking the time to listen and to learn more about this. You can feel free to email me directly, or you can reach out to our general Prevent Maternal Mortality email. Do we have time for questions, or?
I think we have just a few minutes. Please, anybody, you could come off mute or you could put it in the chat. Any questions for Erica? Every time I hear you present, I learn something new.
Well, glad to hear that. We try to make sure we're presenting the most informative information. We have tons of data, and we're happy to always happy to present, and always happy to also provide custom data requests to try to help people get the data that's most important to them.
Crystal, please come off mute. Ask.
Thank you so much for presenting the latest data, Erica. It's really insightful. And I think it's nice to, it's not nice to see the data supporting what we're seeing, but it supports all the initiatives that are in place and really backs up the work that we need to do on those areas. Do you know if I'm grateful. It seems like this last data set came out more timely, I would say, than the last one. Do you think that will be the case moving forward now with our collaborative, that we'll get these data sets more frequently and the interval will be less?
Yes, definitely. So one of the issues was that back in the past, before 2019, we were reviewing cases on a 4 to 5 year delay because we didn't have subpoena protection. So technically, if there's a lawsuit about one of the deaths, they could call in MMRC members to talk about it. And so we were delaying to avoid that. But now with statutes that passed in 2019, we're really working to get on this goal of reviewing deaths within 2 years of the death. We won't be able to be more timely than that just because there's quite a few deaths. It takes a while to identify them, all of that. But the goal is to review deaths within 2 years, which we're actually now meeting. And then the goal from there is to get data out more regularly and to find different ways to get the data out there. We have these legislative reports that are mandated every 3 years, but it's such a big lag to have to wait 3 years for new data. And so currently the best option to getting data more quickly is just reaching out to us and asking for more recent data. But we are working on how can we get different data briefs out or other data products out or other ways to share the data so it's not just living in our brains and in our department.
Wonderful. Thank you.
We had another question in the chat too about, does the report break down obstetric complications?
So it doesn't break down specifically how many deaths were from which obstetric complication, just because some of them are fewer than 5, and so we can't show that. But I can tell you that it includes things like hemorrhage, placenta accreta, hypertensive complications such as preeclampsia, eclampsia, and HELP syndrome, pulmonary embolisms, amniotic fluid embolisms, anesthesia complications, and ruptured ectopic pregnancies. And so if you have an interest in like a very specific obstetric complication, we might be able to pull out the number of deaths from that specific one. But a lot of them are just like, thankfully, rare events. And so we don't have enough to talk about it in more depth.
Great. We're at time. Guys, reach out to Erica if you have more questions. She's kindly put her contact information here for us. Erica, thank you. We appreciate your time and dedication to this data. We know that it's hard data to deal with, and you guys do it so thoughtfully. All right, the last thing we wanted to remind you guys of is that our neonatal facing and quality improvement program Chosen, which is for substance exposed newborns, they're having a forum coming up on October 20th. It is free to attend. It is both for obstetric clinicians and neonatal clinicians. And so if you guys want to post this in your nurseries at your facilities, that would be great. I think, it's mostly geared towards infant care providers, but we wanted to put it out there as a free forum. Their registration does have more information on the topics that they're going to cover at their event, and it usually happens out at the University of Colorado Anschutz campus. All right, is there anything else, Sydney? I think that was probably our last slide. Yes, please fill out the evaluation if you guys have a quick second to do that. And we do have CE for today's event, so please scan. We will also share this out in the follow-up email. So if you attended today and you want to count this towards your CE, please do so. We're happy to offer this as a perk of attending. And we don't really have time for questions, but you're welcome to contact us by email. Let us know if you need anything. Please also know that you can share the recording of this with your colleagues, and if they have listened to the recording, they're also eligible for CE. And so offer that to them as well. We will look forward to seeing you guys next month. We are also on a Wednesday, so the 2nd, this is true, Wednesday. Sydney, correct me if I'm wrong. We will be back with another coaching call. I'm right. Okay, perfect. All right.